An answer can be completely correct and still be wrong. Someone hands you an order, vancomycin, for example, right drug for the organism, right indication, right interval for the patient's weight, you verify it. And nobody has ordered a serum creatinine. Nothing you did was incorrect, but it was half an answer. And the missing half is the half that reaches the patient 3 days from now. I am Ahmed Sabry, clinical pharmacist. In the next 12 minutes, I will give you the 5 checks I run before any medication order or any counseling point leaves my hand. Once it's habit for you, it takes about 90 seconds. I call it I save. Before I start, I want to confirm two things. First, every case in this video is constructed for teaching. These are not real patients. Second, I didn't invent these 5 domains: indication, safety, adherence, effectiveness. These are the standard drug-related problem categories clinical pharmacy has worked with for decades. What I built is a mnemonic, 5 letters, short enough to run in your head, while a nurse stands at the counter waiting for you. That's the entire claim I am making. iSafe is considered the rule of clinical pharmacists to move beyond simple drug knowledge. First indication. I have 4 points under the indication. First factor I need to cover. Is there any drug without indication patients are taking? Is there any indication without drug? Is there any therapeutic duplication? The appropriateness of indication. Is this the first line treatment for the patient according to his condition? Related to safety, any contraindication or interaction like drug or drug disease or drug food, dose adjustment for age, renal, hepatic function, monitoring parameters are covered all like INR for anticoagulant, electrolytes for diuretics, like blood pressure for hypertensive medication, adherence. Is the regimen practical as frequency, cost, route? Does the patient understand instruction? Is there any barriers to adherence, complexity, side effects? Follow up and monitoring. What parameters to monitor? Clinical lab, when to reassess blood pressure in 2 weeks, or HbA1c for diabetic medication, last efficacy. Is a medication achieving its therapeutic goal? Is there any clinical or lab indicators to detect a response? If we go through the indication, right drug for the right problem. I need to evaluate each medication is prescribed, whether my location, to confirm these points. Is there a clear indication for each drug? We talk, for example, omeprazole, like 40 milligram daily, but there is no any indication or diagnosis for GERD or PUD, peptic ulcer disease, or history of steroidal use. So there is no indication for this medication. Consider discontinuation because the proton pump inhibitor can cause hypomagnesemia and clostridial difficile infection. Second point, are there missing indication? It means untreated condition. Example, patient with heart failure, reduced ejection fraction, not receiving ACE or ARABs or ARNI or beta blocker. which means that his medication regimen has shortage. These agents improve survival, reduce hospitalization. So I need, and also omitting them exposes the patient to higher morbidity and mortality risk. Are there duplicate indication? Two drugs treating the same condition unnecessarily, like patient receive ibuprofen and diclofenac as painkiller. I need to stop one of them as high risk of GI bleeding and renal injury. Last point, is the drug the best choice for that indication? Evidence-based and guideline supported. Check if it is first line or second line or off-label use. Patient 45 years old, male, diagnosed as type 2 diabetes, but the doctor started with him glimepiride 4 milligram daily. According to American Diabetes Association 2024, diabetic patient start with metformin, remains the first line for most cases if it is not contraindicated. If we go through the safety, our second tool, right drug, right dose, right patient. Clinical pharmacists should protect the patient by ensuring that every drug is used safely. What's safe for one patient may harm another. Is this drug safe for this specific patient? Check for contraindication factors. Review allergies, age, pregnancy, renal and hepatic function. Watch for disease-related risk like non-steroidal in chronic kidney disease, beta blocker in hypotensive patients. The right drug in the wrong dose becomes the wrong drug. So I need to correct the dose based on patient condition, the route and duration also. Check before you mix, monitor before you risk. Could this drug interact or cause toxicity for the patient? Check for interaction and any needed monitoring, like review drug or drug food or drug lab interaction. Third tool, adherence. The best medicine works only if it is taken on a proper frequency. If the plan is too hard to follow, it is easy to fail. Can the patient realistically take this medication as prescribed? Check for forgetfulness, complex regimens, or lack of understanding. Simplify schedule, once daily dosing, combination medication, a therapy the patient can't afford is a therapy they can't follow. What might stop the patient from taking this drug? High cost, unavailability, or unpleasant side effects, lower adherence. So discuss affordable or better tolerated alternatives. Last point, educate once, follow up twice. That's adherence for life. Does the patient understand why and how to take the medicine? Provide clear counseling, written instruction, and follow-up checks. Encourage feedback and adjust the plan when needed. Teach the like as some technique like teach me back techniques. Our fourth tool, follow-up and monitoring. What gets monitored gets improved. Define what to monitor and when. No monitoring, no control. Follow the data, not the guess. Ask how well we know if the medication is working and still safe. Identify key clinical and laboratory parameters for each drug. Set specific time frames for reassessment. Patient blood pressure monitoring weekly for hypertensive medication or HbA1c every 3 months for diabetic medication. renal function, like for ACE inhibitor or diuretics. Reassess therapy and adjust accordingly. Monitor, modify, and move on. Every plan must evolve with the patient. Is the patient improving or experiencing problem? Compare actual outcome with target goals. Like for example, blood pressure, the target according to latest guidelines should be less than 130 over 80. Low density lipoprotein should be less than 70 in most of the patients, especially with high risk. Modify dose, add or discontinue medication based on response and safety. Document every change clearly with rationale. And our example, like INR if patients are taking warfarin. Efficacy. This is our last tool. Is the treatment achieving its goal from the medication? Evaluate the therapeutic response. If you can't measure it, you can't call it effective. Ask, is the medication working as intended? Check clinical outcome, symptom control, improvement in disease markers. Review laboratory results of or vital signs relevant to the drug's purpose. Compare results with the target goals set by guidelines. For example, as we mentioned, patient on ACE inhibitor like lisinopril for hypertension, I need to monitor serum creatinine and potassium after 1 to 2 weeks, then periodically to detect any early renal impairment or hyperkalemia. Optimize therapy when goals are not met. Don't just continue therapy, confirm it's working or correct it. Ask if the drug isn't effective, what should it change? The dose, the drug, or the approach? Verify adherence and correct administration, escalate dose, switch to another class, add synergetic therapy based on evidence, always reevaluate after each adjustment. Like for example, our goal from HbA1c to diabetic patient less than 7. So I need to assess the adherence to medication and diet and before escalation. Our last point, what is the, if I feel confusion between monitoring and efficacy? This is some points to clarify the difference. Main question, for monitoring, is the therapy safe and under control? But my question different in efficacy, is the therapy actually working and achieving goals? I focus on monitoring on early detection of problems or toxicity during treatment, but in efficacy, I focus on measuring therapeutic outcomes and clinical improvement. My purpose from monitoring to prevent harm and detect adverse effect early, but in efficacy to confirm benefit and optimize results. Timing. In monitoring, its continuous process starts immediately after initiating therapy, but in efficacy, the time evaluated after enough time has passed for drug to show effect. For example, trough for vancomycin and serum create. Serum create consider monitoring, but trough consider efficacy checking. Examples like renal function for ACE inhibitor. Is this drug still safe to continue? Efficacy, HbA1c for diabetes control. Is this drug still worth continuing? Monitoring after 1 2 weeks. Check serum creat and potassium to ensure kidney function is stable and no hypokalemia. But efficacy after 3 months. Check symptoms like dyspnea, edema, and ejection fraction for the patient who's receiving ACE or ARBs. Thank you. And you have to know that you are the only drug expert who can do all these tools.